Welcome, everyone. It's day one of the Making Dad Summit, and right now we're so excited to have Dr. Eisenberg with us, and we're talking about varicoceles. And what is that, and how do you find one, and how do you even know if you have it? So I'm so excited to jump into our conversation. Of course, Sarah is with us today, my partner in crime, my co-host, Sarah Nab. And before we get into our conversations about making dads, I would love to just take this moment and say thank you to Fairfax Cryobank for sponsoring the Making Dad Telesummit. And it's through their generosity that this very important conversation is funded. And in case you don't know, Fairfax Cryobank is the world's largest sperm bank, offering anonymous and ID option sperm donors, as well as storage service for sperm, embryos, and oocytes. And oocytes are eggs. You can find out more information about Fairfax Cryobank by visiting their website or on the landing page for the Making Dad Summit at www.fairfaxcryobank.com. And welcome, Sarah. Thank you for being here with me again. And also, Dr. Eisenberg, thank you so much for taking your time out of your busy day to have this important conversation.
My pleasure.
Thank you, Kristen. I'm so excited to talk about varicoceles today. They're a big issue. They affect about 15% of men, and really thrilled to have Dr. Eisenberg, good friend and just renowned expert in the area of male reproduction, joining us. He is the director of male reproductive medicine and surgery at Stanford, and one of the country's leading researchers who studies the correlation between men's reproductive health and their overall health, and looking at how does fertility kind of impact overall health and vice versa. And some of his research is just incredibly insightful and very important during this Men's Health Month, where we're really looking at what impacts a man's health. And so I'm just so honored to have him join us and talk about something that's really common that can impact men and their fertility, which is the varicocele. So welcome, Dr. Eisenberg.
Thank you so much. I think it's really kind of a tribute that this is just such an important topic, and I want to thank you both for helping organize it, and also the sponsor, Fairfax Cryobank, as well. I think it's good they get a lot of attention on male reproduction as well, because about 50% of the time there's a male component to that.
So let's just start off with varicoceles. What are they?
Good question. So basically they're dilated veins in the scrotum. So testicles are outside the body because they need to be a little cooler. And so anything that warms them up can potentially be a problem. And in some men, there's dilated veins in the scrotum. And that's thought to impair normal temperature regulation. And there's some other theories as to why potentially they can cause issues. Increased pressures in the testicle, not being as efficient in kind of carrying away sort of byproducts of metabolism. Those are all some possibilities, but they're actually fairly common. About 15% of all men have them. And they cause issues maybe about 20 to 25% of the time. So the issues they cause are really kind of threefold. There's kind of three main reasons that we would deal with them. Number one, sometimes they can cause pain. As blood sort of distends the vein, sometimes there can be kind of an ache associated with that, and so some men feel that. Sometimes they can cause shrinkage of the testicle. So that just suggests kind of some problems with the health of the testicle, so that's another reason that we fix them sometimes. And the other thing, obviously very relevant to our conversation today, is they can impair testicular function. And the testicle does two things. It makes testosterone, but it also makes sperm. And so sometimes if there's lower sperm counts, it can be associated with the varicocele. And so to that end, while 15% of all men have varicoceles, if you look at men that are trying to have children and are unsuccessful, it's probably about 40%. So it's a little more prevalent in the infertile population. And so because of that, there's this association that's been identified, and that's, potentially an actionable item that can be corrected and hopefully improve the chances for men to conceive.
So, Doctor, I have a question. So,
Yeah.
And I don't know how to articulate this in a way that it's, so everybody has a sense of normal about their body, right?
Yes.
And you know, part of what I've heard from clients is that they didn't realize that this was an issue. They thought that was normal for them, you know, the amount of heat that is, you know, might be generated by, is that true, generated by having this, you know, excess pool of blood, if that's how you say it? Or I just wanted to address, how do you know that you would have this if what you feel is your normal?
Right, now that's a great question. I mean, usually they come about puberty, and that's probably about the time that most boys or men start to become kind of familiar with themselves, especially down there. So I think that you know, some people probably, if they are struggling with fertility, may have a little bit more appreciation, you know, doing some research online or in textbooks, and things like that. Or if they see providers, they may have a sense. But I think you point out a very, you know, really relevant point that, you know, a lot of times it's not something that you can easily diagnose. You know, usually it doesn't cause any symptoms. You know, things that you would obviously feel. If you have an ache down there, maybe you'd be more likely to be concerned about something and, you know, do a little research about it. But you're not going to feel if your sperm count's a little bit lower. That's not something you would notice. You probably wouldn't necessarily notice if one testicle is a tiny bit smaller than the other. So a lot of times it is asymptomatic, and you know, if it's something that you've had for a long, long time, you may not know that it's an issue. But I think that usually in this country, it's usually brought to the attention because either it's found at sort of a screening physical, either by a pediatrician or a, you know, primary care provider for adults, or at the time of an evaluation for fertility as well. It's commonly seen.
So you said that the testicle has two functions. It makes sperm and it makes testosterone. Is there cases where a varicocele will impact testosterone production?
Yeah, I think that, you know, even with sperm production, I think it's always difficult to say whether or not the culprit is the varicocele, because there's a wide range of normal for sperm production and for testosterone production. But there's certainly been correlations between having varicoceles having a little lower testosterone production, and then even if there's some studies that show that after a varicocele is fixed, testosterone production will increase. So it is another added benefit that we do get after we fix varicoceles. But it's not, I think, not sort of a primary indication to repair a varicocele just for low testosterone.
So, Doctor, I have a question. You know, of course, you had such an informative talk last year during the summit, and the phrase that I use a lot that came out of your mouth was "men wait till they're shot to get you know, checked out and bleeding. You know, if that's the only reason why they'll take initiative." And so, you know, we've been talking about the gap of, you know, the pediatrician when an adolescent, you know, how do you say it, ends their time at the pediatrician, and before they go to a primary care, there's a gap. And so, do you have any recommendations for men about, you know, when they should be seen, or what is the gap, or what, you know, what is the time frame for that, even though there's great resistance maybe?
Yeah, I mean, I think it's a really good point, kind of a fundamental question of why, you know, there's kind of health disparities between men and women. You know, the mortality rate is higher in men, and this has been posited as one possibility for that, is just lack of sort of healthcare maintenance. You know, women are, it's sort of, it's part of it that they're going to go see their doctor. You know, obviously screening recommendations for cervical cancer and things like that have changed a little bit, but they're used to going to the doctor for, you know, regular annual screening, and it's not really built in for men until they get, you know, much older, like 50 or so. So there is this whole kind of, you know, this whole period of time, this kind of reproductive age period between 20 to 50, where a lot of men don't seek care unless there's a problem, unless they break a bone or, you know, there's some other issues. So I do think, though, it's very important for men just to seek care. You know, if everything is, you know, if you feel great, I think that's good, but there can be lots of underlying issues that are going to manifest later on. You know, I think the new pediatric recommendations are actually to consider, you know, checking cholesterol very early in life. I think around the age of 10. So, you know, if that's a recommendation for children, I think it makes sense that, you know, similarly for men or for anybody, you can have your cholesterol checked, have your blood pressure checked, just to make sure there's not an issue. And early on, I think you could probably do a lot of diet lifestyle changes that may not be as available later on if things have been, progressing for some time. So I think there's really a window of opportunity before health issues arise just to maintain. So that's always something that I talk to all my patients about.
So this is where this is my question, which, and Sarah, of course, being the mom of boys also, my son is turning 16 and is driving, and I just went for my annual mammogram.
Yeah.
And in the conversation with him, I talked about self-care, self-checking, and Sarah has to listen to this again. She's been listening to me talk about this. But I said to him, it's very important for you to start self-checking. There's so many literature out there about breast care and, annual, breast exam, self-breast exam. Mm-hmm. So going back to what you said, that a lot of this, a varicocele starts in puberty, right? Yeah. So you have this young adolescent male who's just really finding out about himself and his sexuality, right? Mm-hmm. And so what would be, like the pamphlet for breast exams? What should any man do, for an exam?
Yeah, that's a good question. I think that if there's anything that you feel that's concerning, I think you should always bring it to your doctor's attention. I've taught some men general anatomy because they come in with a finding that turns out to be perfectly normal. But certainly if you feel a change, I also think that's important. Now, testicular self-exams, I think that they do have a place, but they are somewhat controversial. So some organizations actually think that they don't help just because testis cancer is so rare that you tend to find, you sort of create more anxiety than you'd actually benefit. But it's something that I definitely talk to men about that do come in with any concerns down there, to let them know that, no one knows their body better than them. So if they feel any change, definitely come back to see me, and we'll see what we can do.
Well, this is why too, and it's one of my clients brought this up, and I know I'm talking about this, and I don't have a penis, but the couple didn't know he had a varicocele. Mm-hmm. He had his varicocele surgery, and he was brave enough to say, I didn't realize how when my testicle was in shorts or in boxers or in briefs was sticking to the side of my leg. It was because after the surgery he didn't have that, and that was normal for him, because he thought. So I hope the direction of the conversation or questioning is just trying to answer that. So I know that if other clients are watching this, that you don't really know, but the most important thing is to, if you notice a change, to go to the doctor, seek help, or seek advice, or seek an exam, right?
Right, and I think I think that's a really good point. Obviously I've done several genital exams in my career. And a lot of practitioners have done as well, but most people that aren't in the healthcare field will not have done that. So I think they don't know normal. So the other thing that you can just establish the relationship with your primary doctor is they'll look you over from head to toe, and see if everything looks normal or if there's anything that they should keep an eye on a little bit closer. So I think that's important.
Okay. So coming back to the varicocele, a lot of couples are faced with all right, we have we get a semen analysis, we find out there's some abnormalities, either some motility issues or some morphology or some count issues, and now we've done an exam, we find that there is a varicocele involved, and now what are the next steps or the next things for them to be thinking about in terms of their game plan?
Yeah, well, that's a great question, and I get that all the time. I think the question is what to do next. And I think it's important to know that there's no absolute right answer. I think it's just what feels right for you. So I think there's a lot of pathways, to get to a child. So I think that I talk about all the options, and certainly varicocele repair is one option. We talk about the timing of sperm production. So it probably takes about 2 to 3 months to make a sperm. So whether we do surgery to fix a varicocele, some men have conditions that we need to give medicine for, so we're going to do that. If they're going to change some lifestyle habits that may have some benefits, it's going to take a little while to manifest. It'll take 2 to 3 months. So just so they're kind of aware of that time frame when they're thinking about things. So reproduction is a team sport. So we obviously also want to see what's going on with his wife or partner and see if there's any issues there that may kind of dictate one line of treatment or another. And the other treatments would be obviously for varicocele. we're hoping for, just being able to have just intercourse, timed intercourse, just regular intercourse to have a child. There are also some higher levels there, like intrauterine insemination, where we take sperm, put it inside the wife's uterus when she's ovulating, or even in vitro fertilization, where we mix sperm and eggs together in a dish. So just trying to find out together, give them all the options, let them know the benefits, the risks of all of these choices, and hopefully they can come with sort of the right decision for them. Sometimes what we do, if they are kind of in a hurry, because a lot of times, unfortunately, male evaluation tends to be bypassed early on in an evaluation, because men, I think, don't really realize they could be the cause of infertility, and there's sort of this perception that it's usually the woman's, that's usually, kind of a female cause. But it turns out about 50% of the causes are male factor. But, if you look at couples in this country, probably about 20-25% of the time, the male's never evaluated. So it turns out that when he is, it's probably a little later on. And so if a lot of time has passed, couples may really want to kind of move forward with some of these more aggressive technologies, which I think is fine. But if we're thinking about, this is their first child, maybe for their second child, it may make sense to start to do some things now to optimize everything. So when they're trying for their second child, they're in kind of a better place. So I think, even if they want to do maybe inseminations or IVF for the first child, hopefully if we fix everything, optimize sperm production for him, by the time they're ready for their second child in 1, 2, 3 years, things will be a little bit better.
So are you talking about a non-surgical approach to, I don't want to say addressing the varicocele?
Well, there's two, yeah. I guess when I spoke about medicine, I wasn't speaking specifically about varicocele, but for varicocele, there's two main options for treatment. So one is surgical, and that's
okay.
Go in and actually tie off the veins. There's also a radiologic procedure called embolization, where glue or other agents are injected inside the dilated veins to basically clot them off.
Wow, okay. And so that would, of course, have to, if you didn't, I didn't realize about the second one. So that would also go in tandem with creating your plan.
Right. Yeah, we're thinking about how to treat it. Yeah, so for the surgical treatment, it's an outpatient procedure. It usually takes probably about an hour or so per side. Typically, incisions now are made very small. They're about an inch or so. We use a microscope so we can precisely see all the veins in the area and also not injure other structures that we don't want to injure, like the arteries, which are bringing blood to the testicle, which obviously we want to preserve, the vas deferens, which brings sperm back, which we obviously want to preserve. So there's some advantages to the microscope, so we can see more veins and protect more structures. So it's an outpatient procedure. Usually men recover over a few days. No exercise for a week is my ask, and then they can let pain be their guide at that point. The embolization is sort of a similar time frame and recovery. I think it kind of depends on local expertise, which is done. The literature suggests that there may be a slightly higher incidence of recurrence, so the veins coming back with the embolization, and that's because the embolization targets one set of veins that drain the testicle, whereas the surgery can kind of get some of the accessory pathways as well. So there's kind of theoretical advantages, and it is borne out a little bit in the literature that there's a lower recurrence rate. So I think for that reason, a lot of people do favor surgery for the initial presentation, but if they do come back, which sometimes they do, embolization, I think, is reasonable for recurrences.
So, Doctor, we actually had a question that we were hoping that you would address about varicocele.
Okay.
And I think this is the perfect time because you're giving the options of corrections.
Okay.
So it would be, let me find it. After having surgery for varicocele, how long would it be to see a change or different test results? And what do you do if there's no improvement?
Yeah, this is a great question, and this obviously comes up every time we talk about varicocele treatment. So we see improvements probably 60 to 70% of the time. And again, the time frame for sperm production is 2 to 3 months. So usually we start to check sperm counts probably about 3 or 4 months afterwards. So sometimes we start to see improvements as quick as that, but sometimes it can take a little bit longer. The varicoceles they're kind of chronic insults, so they've been there for a long time, injuring the testicle, and so it can take a little while for the testicle to recover. So there is some recovery that I've seen in men 6 months, 9 months, even up to a year afterwards. But again, it improves things 60 to 70% of the time. So there is a small population of men who don't benefit from varicocele. Again, they cause a problem 20 to 25% of the time. So there are a lot of varicoceles that, for whatever reason that we don't understand, aren't the issue. And so even if we fix it, there's some other underlying problems that are still kind of keeping sperm counts a little bit low. So we do see that sometimes as well.
So does that go hand in hand with a recheck for testosterone levels after you have the surgery?
Yeah, the way that I follow them, absolutely. I check sperm count, certainly. And if there was any kind of issues with testosterone or some of the other hormones kind of involved in that axis, I'll check those again during follow-up as well to see where we stand.
Okay.
Is there anything else that people can do in that recovery period to help heal the testicle?
Well, I think, we look very comprehensively at sort of lifestyle factors that can impact testicular function and sperm production. So we'd really try and optimize things. And I think I always start by saying anything that's good for the heart is good for fertility. So we talk about good diet, exercise, maintaining a good body weight, stopping smoking for some of the men that smoke. I think that's very important as well. And then talk about some of these external heat sources that some men do. Laptops in the lap, and as quick as just 20 minutes, it can actually, the laptop in the lap can actually warm the scrotum up about 1 degree, which is enough to impair spermatogenesis or sperm production. So we talk about stopping that, making sure they're not doing hot tubs, saunas, hot yoga. Those sorts of things can all be detrimental. So we kind of look at all these individual factors and hopefully all together can do some improvement. The other thing that there's reasonable data for is antioxidant therapy. So a lot have been looked at: vitamin E, vitamin C, L-carnitine, zinc, coenzyme Q. I oftentimes recommend a multivitamin, which will have most of what you need. I think too much of anything can be bad. But there are some products on the market as well that I think are fine. So some men that are on them, we keep them on it. I think they do a good job. So those are kind of the main strategies that we use.
That's so important, because that was another question too about antioxidants.
Yeah.
And once again, the landscapers guys are here, but we can edit this out. But the question I'm going to ask you about the antioxidants, but
okay.
The question actually, doctor, was: are there any nutritional steps to take, our supplements, to overcome anti-sperm? And what about antioxidants?
Yeah, so I think that there is good data that antioxidants help. And again, there's a lot of antioxidants that are on the market now. And I think that, I don't have an affiliation with any particular brand. I think some are good. And I think if men want to take those specific blends, I think that's fine. The specific ingredients that I think have been studied reasonably well are vitamin E, vitamin C, L-carnitine, zinc, coenzyme Q is another one, and I think combinations of those make a lot of sense. Most of those are going to be in multivitamins, so I think that's fine to take. The other thing that I also talk to men about is trying to supplement their diet with foods that are rich in antioxidants. So dark berries, blueberries, blackberries, things like that can also help. There's sort of other ways to get those antioxidants.
That's so important because of the subtle little changes and how important. Also, after surgery, if you make the subtle dietary changes, is there any studies that correlate with the subtle dietary changes in recovery?
Oh, that's a good question. So far most of the data is looking kind of at a single point in time. So it takes men looking at their sperm count and looking at their diet now. I think changes in diet have not really been studied as well, but we sort of make some inferences. If men that are eating less healthy, more processed foods, higher fat foods have lower sperm counts, whereas men that don't have that same diet have higher sperm counts, it makes sense that there may be some relationship there. And I think making those recommendations I feel good about. Hopefully it'll help their fertility, absolutely. But there is certainly good data that it's going to help their health. It'll help longevity, help them feel better, help their vascular health, their heart health. So I feel very confident that when I'm making these recommendations, I think there's reasonable evidence that it'll help sperm production and fertility, but it can certainly help their overall health.
Great. Thank you so much.
Mm-hmm.
I think one point that we talked about that is really important to circle back on just shortly is this idea that men should get evaluated early in the fertility journey because their options are more open or more there are more options when you do this early on and you have more time, because it takes time to heal the body. It takes time to heal her body, and it takes time to heal his body if there's something going on. So what would be your recommendations for a couple that's just starting out, or you know, a couple that's thinking about starting their family? When should he be thinking about an evaluation, and you know, what should he be doing on his side in the early stages?
Well, I think that's a great question. You know, so the definition of infertility is unable to conceive after a year. So I think most people would just recommend trying at least a year to get pregnant, and if you don't, then you can come see you know, a healthcare provider. You know, if you look at couples in their peak fertility, and that would be probably late teens, early 20s, the chance of getting pregnant every month is not 100%. It's much lower. It's probably 15, 20, 25%. So it can take several cycles for couples to conceive. And, you know, obviously that's peak fertility. Nowadays we tend to wait a little bit longer before we're trying to have kids. So just to be aware that sometimes it can take a little while. It's not a, you know, perfectly efficient system. But I think if there is any concern, you know, that the man has, he's had some prior health issues, he's been undergone some, you know, some kind of treatments, maybe he had cancer in the past or something like that, something that maybe would put him at higher risk for fertility concerns, then absolutely he should see somebody, I think, very early on. I would say he shouldn't necessarily wait the full year. But as you're kind of going through this first, you know, the first year, first trying to conceive, I think it's important to know these kind of factors that would impact fertility. And I think that's when we kind of go back to this, you know, the health model of, you know, just kind of taking care of yourself. You know, everything in moderation. So trying, if you drink a lot, trying to cut back a little bit, making sure you exercise, maintaining a good body weight, being very kind of conscious in terms of what you eat. I think each of those individually is probably not going to make a huge difference to sperm count, but I think together they probably can. So I think that, you know, taking that kind of very holistic approach, I think, makes a lot of sense early on.
So, Doctor, just to circle back one more, that's so important what you said. I thank you again for bringing that up. But is a varicocele something that you're born with, or is it through a trauma?
It's not associated with trauma, I think, in general. Yeah, we think it is congenital, and actually there is some, you know, it can be heritable too. So if you look at, you know, some families, it does tend to run in families, fathers, sons, you know, brothers can have them together. So a lot of times when I see men, I will ask them if they have, you know, a sibling that should potentially be evaluated, because the incidence can be as high as 50%. So it is, you know, there are some genetic components to it, absolutely. There may be some other factors that are not totally understood. There is some correlation thought to be with body mass index, you know, kind of overall body size. But in general, I think the kind of largest factor that we think about is probably genetic at this point.
And the genetic component comes from the father's gene?
Well, not necessarily. We haven't kind of mapped it out precisely. So it could also be, it could, I guess, in theory, come from the mother's line as well. You know, it could be kind of a thing on the that an uncle could have or something like that. But it is possible. It does tend to run in families, so it could come down with the father, but not necessarily.
So isn't that interesting that, you know, we talk about health issues, and I don't think I've, you know, in my family, not one man has said I have a varicocele. Do you know what I mean? So yes. How would you know it would be in your familiar lineage?
Yeah, I think, well, you know, we kind of look at, when I'm evaluating people, just ask about family history. Did anybody, you know, have a history of infertility, took a little longer to conceive, and things like that. And sometimes, you know, you do have a sense of, you know, everybody has 5 kids except for this one uncle who only has 1, took them a little longer. So I think sometimes families do talk about it to some extent, or maybe it's kind of unspoken, but you do notice some differences. But I'd say it is probably unusual to talk about kind of any issues down there in general, like at a Thanksgiving gathering or something like that.
Right, right.
For most families.
Right. Well, that's such an important thing because my son's dad, that was part of our journey. We're not married anymore, but my ex-husband had a varicocele. So just you saying that it's a familiar line would be now my poor 16-year-old. I'm not going to just talk about self-care.
Yeah.
I'll have to say, oh, you know what we have to include on your family history now? Just as heart disease, it should be that mainstream, right? That is a condition, that's important to know.
Absolutely, absolutely. I completely agree.
Okay. Well,
yeah, I would say talk to mom. Just, if you're out there and you don't know, a lot of guys have a decent relationship with their mom. Speaking from my own brothers, I mean that mom's kind of the heart of the family, and mom knows a lot of the secrets. So that'd be a place to start if you don't know. But I think that's a really big nugget to say.
Yeah.
Hey, if you have any guys in your family that have had any issues, then that is a risk factor that you should be thinking about for your own self.
Yeah. Absolutely.
It's probably not on Ancestry.com, right? So
Not yet.
The varicocele line.
Varicocele line. Is that on here? But thank you for that, because it is. There has to be someone who holds that information. And I don't think if you don't walk in the fertility challenged shoes, then that's not even in your awareness.
Right.
And if we connect the dots that a man's reproductive health is so intertwined and correlated to his overall health, that's an important bit of information for men to know.
Yeah, I think that's true. Yeah.
Okay. Well, thank you so much.
You're very welcome. This was terrific. Thank you for putting this on. This is a very important topic. I'm very passionate about it. I think hopefully that came across.
Well,
so, Dr. Eisenberg, if people, watching this are thinking, well, maybe I have something going on, or maybe I want a second opinion, or I wonder what he would think about this. Is there a way for them to reach you, or to reach out to you?
Yeah, absolutely. They can email me. My email is just my last name @stanford.edu. We can kind of point you in the right direction.
Great. We'll put that on the landing page also, and after the summit, everyone who registered is going to get follow-up information for all the presentations.
Oh, terrific.
So that, we'll put that all in one place for everyone, so they can find you easily.
Great, perfect.
I also think I should share, I have on Don't Cook Your Balls, we have a resource that Dr. Eisenberg has helped to review a risk assessment that allows men to go through and fill out questions relating to their family history, their symptoms, how long they've been trying to conceive, their diet, exercise, everything about their life, and it will point out any risk factors that are in their life, which could help them to figure out if they do need to go get evaluated sooner than later.
That's awesome. So we'll include that under Dr. Eisenberg also, so that maybe the first step would be to take the eval and then reach out to you after they get that information that you created from that.
Yeah, it's a very neat tool.
Great. I know, I took it.
Okay.
So you're varicocele, Kristen?
No, I didn't have one of those, but I took it just to see so I could talk to it when I talk to my clients about it's easy peasy, just go take it. Okay, on that happy note, thank you both for your time in addressing the varicocele, because I think that should be mainstream conversation. It should be out there about them.
Hopefully. One day.
One day. All right. Thank you so much.
Thank you.
Thank you.